All right. Happy April, everybody. Welcome to this Debbie's Dream Foundation webinar. This is the April Town Hall. Today is going to really focus on sort of nuts and bolts of new diagnoses, questions that should be asked, things that everybody should know, standards of care, etc. I'm Sam Klempner. I'm a GI medical oncologist at MGH in Boston, and I'm going to be moderating. If you don't know how to use Zoom, then I don't know what to tell you, but chat function is the best way to get questions to us. Feel free to ask anything you want. The people that submitted questions ahead of time, we will do your questions first, and then we will get to the rest of the questions. I'm joined today by two awesome GI oncologists also in the Northeast. Dr. Ryan Moy at Columbia in New York, and Dr. Sam Cytryn at Memorial Sloan Kettering, also in New York. So we're going to start this off with a question, mostly so we really know who's here. So if we could bring up the first question, which is really about when were you diagnosed with stomach or esophageal cancer? Is this a very recent thing, something you're settling into 2 to 5 months, 6 to 12 months, or more than a year ago? You probably can all see the poll. Give it another couple seconds. Right now, about half of people more than a year ago, and then a pretty even split between 2 to 5 and 6 to 12 months ago, with nobody just recently diagnosed. So this will hopefully be relevant to everyone. You should be able to see the results. But that was the questions of the poll. So before we get into the pre-submitted questions, I'm just going to spend a little bit of time walking through some basics. And again, you can also raise your hand if you know how to do that. Sometimes I mess that one up, but you can raise your hand in Zoom and we can call on you later on. But let's just start with some basics for standard of care. And Ryan, I'll come to you first. You know, someone comes in, new, trouble swallowing. Take us through staging and also maybe things that people sometimes come without, like maybe laparoscopy, etc.
Yeah, and thanks again for having me here. So that's a common scenario that how we'll diagnose stomach cancer in patients who may have difficulty swallowing, also known as dysphagia. Um, so usually these patients are seen first by another doctor, such as a gastroenterologist. Oftentimes they'll have an endoscopy where the gastroenterologist will take a camera to see, what's going on, what's causing difficulty swallowing, and then get a biopsy. And that'll be important for determining the diagnosis of stomach cancer. And at that point, they may come to us or they may be referred to oncology through a surgeon. Um, so patients who are diagnosed with stomach cancer, I think one of the um, first important questions are, what stage am I? And there are several tests that are involved in helping to determine the stage of a patient's cancer. Um, Oftentimes that includes a CAT scan with contrast of the chest, abdomen, pelvis, and that's to look to see, is there any evidence of the cancer outside the stomach, such as in the lymph nodes or in distant parts of the body. For patients where there's no evidence of any spread, it may be that it's an early stage cancer or cancer just in the lining of the stomach. Oftentimes, we may have the gastroenterologist do a special test called an endoscopic ultrasound that can use a special type of camera with an ultrasound to see how deep the cancer is into the stomach wall, if there are any lymph nodes that are involved, and whether the cancer might be amenable to procedures that the endoscopist can do, where they can remove the tumor. Other tests that may be helpful with a diagnosis include sometimes we'll have patients get a PET scan. That could be helpful for detecting metastases that aren't apparent on other imaging. In addition, as Dr. Klempner pointed out, for patients who have had staging scans and may have a localized gastric cancer, so just involving the stomach or lymph nodes, it's also important to consider a diagnostic laparoscopy. So this is a procedure that the surgeons can do to take a camera, look around outside the stomach to see if there is any evidence of spread of the cancer. They'll also do some washings to see if there's any cancer cells that have spread and could be evidence of a more advanced cancer.
Yeah, I think that's exactly how we approach the same problem. Ryan, Sam, I'm gonna come to you with this one, which is, so let's say a patient has CT scans that have no evidence of clear regional disease, and they say, I want this out. Are there people that you think about surgery first, or have we kind of moved away from that?
I think, we do see patients who come and have that as their first question, and in a lot of ways, it's very understandable. You have this cancer in you, you want it physically out of you, and there's a lot of reasons for that. But in anyone in whom the cancer is not very early stage, in which it is very small, even if there's any lymph nodes that we are concerned about, or if it's big enough that it's causing you trouble swallowing, a lot of ways, that's already a signal to us that the cancer has invaded through parts of the wall of the esophagus or parts of the stomach, that there may be microscopic metastatic cancer cells. And so when that's the case, even in this hasn't spread far away, but sort of middle stage, I think there's pretty strong consensus that the best strategy is to start with systemic therapy. And in the large majority of cases, that includes chemotherapy, and a minority of cases that may include immunotherapy, but generally systemic therapy with two main goals, which is shrink the cancer that we see and work to eradicate the cancer cells that we don't see. And then following, after a period of that time, going to surgery and removing what's left, and depending on how much is left, and again, depending on some specifics of that, oftentimes continuing with some therapy afterwards.
Yeah, totally agree. I think it's always tough when we have patients, sometimes sent in from outside and they thought they had an early cancer, then you get a surgery and you had a positive lymph node, and then you're dealing with a different situation after surgery, and you've got a bunch of chemo coming your way, which is not easy after a big operation. Ryan, you talked a little bit about diagnostic laparoscopy. So while we're still sort of on the main topics, there's a question in the chat, which is, I'll reframe maybe a little bit, which is, if and when do you ever think about laparoscopies in people with stage 4 cancers?
That's a good question. So a laparoscopy can be helpful for assessing peritoneal disease, and this means cancer that may be involving the lining of the abdominal wall or lining of the intestines. Not all patients with stage 4 cancers need a laparoscopy. Oftentimes, again, we're getting a diagnosis to try to identify whether there's any, peritoneal disease in the first place, usually in patients that don't have obvious signs of it on like a CAT scan. I think, there are, newer, there's a lot of new investigation in trying to target and understand how to best treat patients with peritoneal disease. And so, for instance, sometimes we may want to reassess the response after getting some treatment, some chemotherapy, to see how well the peritoneal disease has responded. Again, if we're considering some of these more intraperitoneal therapies or potential of surgery, which is not the normal situation for most patients. and so that's a situation where we could consider diagnostic laparoscopy in stage 4 disease.
Yeah, agree. I think it's always kind of what are you going to do with the information that you have? If someone's got scans and spots in the liver, probably laparoscopy is not going to change much for you. But I completely agree. There is a lot of unmet need. I think we see from these town halls every week and month that peritoneal disease remains a major topic of discussion. Partly because the data is kind of all over the place. But let's go back to you, Sam. So talk a little bit about sort of when someone comes to see you as a new diagnosis, the things you want to make sure they leave the appointment understanding, or questions that you think people should ask that don't ask.
Yeah. I think we've talked a lot about, staging, and while those things are happening in parallel, one thing Ryan mentioned that we do is when we get that biopsy, we want to not just, see that this is esophagus or stomach cancer, but now the treatments are really being personalized, because it's not just chemotherapy. And while chemotherapy is a part of most patients' treatments, it is what can we add in addition to that to improve the responses, lower the chance of the cancer coming back. And so that's really driven by the biomarkers. And at this time, that is mostly done on tissue, for the purposes of standard of care. And what I always, especially, thinking about a patient who's coming for a second opinion and going somewhere else, if I don't have all of the information, want to make sure that they know to ask their oncologists, what are my biomarkers? And right now there are 4 standard biomarkers as mismatch repair proteins, which, to make things a little bit more confusing, some people is also microsatellite instability. Both of those for our purposes mean essentially the same thing. There's HER2 expression, PD-L1 expression, and Claudin expression. And each of these indicate to us whether or not your tumor is likely or not to be sensitive to immunotherapy or an antibody targeting one of those proteins on the surface of the cancer. And so adding, a certain treatment in addition to chemotherapy is really driven by that. So that, I would say, is in combination with stage, the other most important thing.
Yeah, I agree. I think that message seems to be getting out there, more and more people getting better biomarker testing, but certainly very, very critical. I think we covered sort of the very bare bones, nuts and bolts, and a lot of stuff will probably come up through the discussion. So I'm going to move on to some of the submitted questions. So Ryan, I'll come to you with this one. It has to do about maintenance therapy in advanced settings. So this comes from Lisa. I will just read the question. This is 55-year-old with advanced disease, metastatic to the peritoneum, 12 cycles of Folfox and nivolumab, and then 17 cycles of FOLFIRI and nivolumab, with recent scans apparently looking good. Signatera test is negative. So let's say 17 cycles of FOLFIRI and nivolumab. Like, when do you start to think about backing down the systemic, and how do you think through sort of maintenance? You can say in the first or second line.
Yeah, so maybe we'll start with the first line setting. Oftentimes in the first line setting for metastatic disease, patients will get combination chemotherapy with 5-fluorouracil or capecitabine plus a chemotherapy called oxaliplatin, a regimen called Folfox or Capox, and then addition of other targeted or immunotherapy treatments based on the biomarkers such as Opdivo or nivolumab, particularly for patients with PD-L1 positive or high tumors. And so oftentimes we'll give around 8 to 12 cycles of that chemotherapy. One important side effect of oxaliplatin is that it can cause numbness or tingling of the fingers or toes called peripheral neuropathy. And even after we stop the oxaliplatin, that can worsen before it gets better. So, there's a bit of a limit on terms of how much of that medication we can give. So for that reason, in the frontline setting, oftentimes after patients have gotten their initial cycles of chemotherapy, we'll start to think about, what I refer to as maintenance treatment, or sort of de-escalating some of the treatment to help mitigate some of the side effects and make it more tolerable. As long as the patient's, responding and doing well with the treatment, and their tumor is at least stable or shrinking with the chemotherapy. So in terms of maintenance, then oftentimes we'll take out the oxaliplatin, and patients may be continuing on with the capecitabine or 5-fluorouracil, and also oftentimes with the immunotherapy as well. For later line settings, some treatments, may, have different side effects profile. They may be able to tolerate it a little bit longer, like the FOLFIRI treatment, as you mentioned. It's not not sort of standard to give the immunotherapy with the FOLFIRI, but sometimes that may be given in discussion with the patient's oncologist. Patients can be on that treatment for longer, but there can be some cumulative side effects of chemotherapy that build up also, effects on blood counts, fatigue, other side effects longer term. So then we can also think about going, de-escalating some of the chemotherapy as well, going down from 2 chemotherapy to 1 chemotherapy drug, for instance, but still keeping close surveillance on the cancer. With regular scans, some additional blood tests, as mentioned, could be helpful as well in terms of helping to guide treatment.
Yeah, I think we're all somewhere in that 3 to 6 months of initial chemo, and then backing off to some type of maintenance. Usually less than 6 months, at least in my own experience. But totally agree. Sam, I'm going to come to you with this question, which is also in the chat, but was also submitted ahead of time. This is another common topic. So someone just had a partial gastrectomy, in this case, just, less than a week ago. When you see people, post-op, usually we see them to review their pathology, whatever, 2 weeks post-op. What are sort of the general guidance? I know a lot of this is, we're all at places that are lucky enough to have big multidisciplinary teams. But sort of what is general principles of post-op recovery, especially when you're thinking about future adjuvant therapy potentially?
Yeah. The two things I'm thinking about in parallel is, one, how is the person doing, right? Because, presumably this is someone who had chemotherapy before, but certainly if they haven't, you want to make sure that the person is feeling well enough and having recovered from surgery. And so for the most part, that means that they're able to, because when you've had part of your stomach removed, or a larger part of your stomach and esophagus removed, you have to learn how to eat in an entirely different way compared to how you did for, it looks like, the better part of 8.5 decades. And so it's a learning process, and you will initially lose weight, and then it takes time to be able to stabilize your weight and eat small, frequent meals, prioritizing calories, prioritizing protein, things like that. Because as with chemotherapy, it's a shotgun, it's a sledgehammer. And so there is, looks like the majority of the people on this call know, or certainly the family members who they're caring for, there's a dip, and you need to be able to recover from that dip over that period of time. So certainly making sure that a person is no longer losing weight and feeling like they're getting more active and improving and trending in the right direction. The second thing that we think about is, even if they're feeling well, chemotherapy interferes with wound healing. And so we want to make sure that from, their surgical wound is healed, that the feeding tube was in, the feeding tube is out there, or that at least there's, it's imminently out and there's no complications from that perspective, because that can certainly make things worse. And just kind of as a general point, because I know this comes up with a lot of these sorts of town halls, is patients asking about surgery, and we talked about in the beginning, is it's not just that surgery, of course it removes what we see, but it also means that there's a period of time after which a person has to recover, that they can't be on systemic treatment. And so it takes time for the person to recover and for the wound physically to heal.
Yeah, I agree. I won't ask you about cooking recipes, but
I
I
wouldn't
don't
take
have
my
any
advice on
either.
that anyway.
Ryan, I'll sort of a similar situation, but that window from surgery to adjuvant therapy, what is it typically in your experience? Like, how long do people usually need to recover before they're ready to go back?
Yeah, it generally, one, not all patients, unfortunately, can recover to receive adjuvant treatment. It does again take some time to learn to adjust to the new anatomy, regain weight. In terms of timing, and it's generally a few weeks. Usually, I try to start if we're going to do adjuvant treatment between 4 or 8 weeks after the surgery. And we want to make sure that patients are, eating well and starting to at least stabilize and to regain their weight before we start. So, and it's usually a few weeks.
Yeah, I think that's agree. I think, even in our trials, it's close to 25% of people that never start adjuvant therapy. It's tough. I mean, it's important, but it's tough. We totally recognize that. I'm going to move on to this submitted question about genetic mutations. Sam, I'll come to you because both of our all of our institutions do a lot of tumor sequencing. It's related to all of our own research. So someone asked about how to handle genetic mutations and specifically CDH1 and catenin A when positive. Do you make sure this is being handled by the genetic counselors? Do you stay involved in that? How do you start that discussion? And
Yeah, it's a
maybe
really good
back up,
question because
maybe back up 1 second. Who do you test and include that?
yeah, because it's a minority of patients, who have an underlying inheritable genetic predisposition, but it's important to know up front. And so certainly anyone who is having any sort of family history, having any sort, on the younger side, and we are seeing this in younger patients, and or certainly certain if they have any of other cancer history themselves, but even if they don't, family history, younger age, because if you don't test, even if it's rare, if you don't test, if you don't look for it, you don't find it. Um, and we work, like you mentioned, we're quite spoiled to have a great clinical genetics team, and so we work very closely with them. It, for something like CDH1 mutation in someone who does not have stage 4 disease, and you certainly want to think about not just treating the gastric cancer they have, but also working to prevent any future gastric cancers. And so in those situations, you might be leaning towards a total gastrectomy, whereas you otherwise might not be. Um, and then there are some perhaps molecular features that go along with certain genetic predispositions, but those in and of themselves don't necessarily guide treatment. It's a lot to do with the, you know, somatic mutations, right? So not inherited genetic mutations. But so it's important to know, and because it, of course, has implications for the family members as well.
Yeah, totally agree. Ryan, I'm going to come to you with this next question, which is sticking to the sort of biomarker sequencing theme. So someone submitted a question, which I don't know that we have a great answer to, but question is, why does the tumor marker change depending on the section of the biopsy studied or the timing of the biopsy? Why would Foundation get a different result from Tempus or Caris? And is this testing or is this science?
That's a great question, and I think sort of speaks to something called heterogeneity or differences within the tumor, and this can be spatial heterogeneity. So within a tumor, one part of the tumor may look slightly different than the other part of the tumor. There may be differences in the alterations or markers that are expressed. So for example, with HER2 or PD-L1, there may also be some differences or heterogeneity between a primary tumor in the stomach or esophagus and a metastatic site, so a site that's spread in biopsy, be it the liver, lung, or peritoneum. So there can be that spatial heterogeneity that may lead to differences in testing from different sections or different biopsies. There's also temporal heterogeneity or changes over time, meaning that that tumors, may evolve, for example, after treatment, and there can be some differences in terms of getting at biomarker testing at diagnosis, and then patients may have a later biopsy, and some markers may be slightly different, such as the PD-L1, getting a biopsy, at a subsequent time. So there can be those differences. In terms of the different, platforms, there are some some slight differences in the exact assays of how they're doing it in general. They're looking at doing sequencing to look at genes that are related to cancers, see if there are any mutations or alterations such as amplifications or deletions in genes, and many now offer immunohistochemistry tests that may be also standard biomarkers from pathology.
And just to make it a little bit more clinical, let's say patient had their surgery and then 3 years later they came back and you have a lymph node biopsy. Do you test both of those? If so, would you use the testing from one preferentially over another or no?
Yeah, so I think I always try to use the most recent biopsy. So if it's been 3 years, there can be some differences in what that represents that lymph node recurrence versus the primary tumor. So I prioritize getting the lymph node, the biomarker testing on the lymph node, because that would be more representative of the cancer that's recurred and what we may want to target in terms of treatment. But if the initial stomach was the biomarker testing was done previously, if it's been that long with between the time of the surgery and the cancer occurred, I'd recommend repeating the biomarker testing.
Yeah, I agree. I think you explained it well. I'm trying to keep an eye on the chat, but also please feel free to raise your hand, because sometimes the scrolling list, I'll try to keep my attentive to it, but also feel free to raise and you can ask your questions live. I'm going to go to you, Sam, about this one because it's something that's probably going to come up more in the future. But let's say someone had FLOT, then a total gastrectomy, then they're going to finish adjuvant FLOT, and then afterwards, how do you follow these people, especially if there's nothing to see on a scan? And are you starting to think about blood-based testing?
Yeah, that apprehension about the CAT scan, it didn't show it initially, but now it did, is very common. And that was, one of the things that Ryan talked about with initial staging, particularly if the CAT scan doesn't show anything else, is why we get the PET scan. A CAT scan can show things in more detail, but notoriously, the esophagus, the stomach, the GI tract, just as it's a tube, it's very difficult. A CAT scan has limitations. And the way I sort of explain it is, if you think about it, colon cancer screening is not done with CAT scans. It's done with direct visualization with a colonoscopy. And so we expect that, but when you've gone through chemotherapy and surgery and had the primary tumor removed, what we're most vigilant in trying to look for is making sure the cancer doesn't come back somewhere else. And so when that's what the goal of the test is, you want to make sure that it has the most detail. And CAT scan is able to show things at a smaller size than perhaps a PET scan. And so you can start with a CAT scan and follow up with a PET scan. The question about blood-based testing is really a great one, and one that I think most, if not the large majority of our trials are looking at now. It is not in any way standard at this point for monitoring. There are tests like Signatera that you mentioned, where we're learning more and more that if the test itself is positive, even if we don't see anything on a CAT scan, there is a heightened likelihood that the cancer is going to come back, unfortunately. And a lot of times it seems almost inevitable compared to if the Signatera is negative. But what we don't know, the important question that follows it is, does treating earlier before we see it, if we actually change the overall outcome, or are we just exposing patients to chemotherapy and the side effects and the toxicities for a longer period of time without actually helping people live longer and feel better? And so because of that unanswered question, it's not standard in my practice, at least, and that's, but I think it's probably something that we will, as we learn more about it in the coming years, we'll have a better sense of when the right time to use it will be.
Yeah, I think we offer commonly, but have a very careful discussion ahead
Yeah.
of time saying, if this comes back and it's positive, it's going to make us both probably more nervous, but we have no data to act on it. And I mean, even in other tumors, when people have tried treating numbers, it hasn't led to longer survival. So I agree with you. It's cool technology and promising, but not yet standard. Ryan, I'll ask you the same question, but this time move it into stage 4 setting. The question from Frank in the chat about ctDNA in the advanced disease. Do you use it for everyone? Are there particular situations where it may be more helpful or less helpful, targeted therapies, etc.?
Yeah, that's a great question again, and we still don't have the answer of how to best utilize it in that setting. There are studies suggesting that it can sort of correlate with treatment response. So if we see circulating tumor DNA decreasing, that may indicate that the cancer is responding. But if we see it increasing, that may suggest worsening. I think, again, one important thing is that not all tumors make circulating tumor DNA, especially, for certain sites, like tumors that are just sort of in the peritoneum. Those that tend to be less likely to have detectable ctDNA. I don't, it's definitely something that I don't use routinely especially for stage 4 disease. There are some situations where it has been helpful. So say, in my practice, and again, this is specialized cases where we're able to detect a targetable alteration for example, ERBB2 or HER2, and they've had a circulating tumor DNA test. We've repeated it in the future, and maybe we can track sort of the levels of that. But again, these are sort of unique situations.
Yep, I agree. That's sort of my approach as well. Frank, I'm going to give you 2 questions because your second one is up there on the screen. And Sam, I'll come to you for this one. You've had a lot of experience with capecitabine over trials. And so for those, hand-foot is HF syndrome on capecitabine. So just talk a little bit about how you adjust capecitabine when patients are on it.
Yeah. And the dosage schedule that you're describing is exactly the way that we tend to start it. 2 weeks on, 1 week off. Usually, initially we'll lower the dose, and then the 7 days on, 7 days off when you get towards a maintenance period is something that is standard, and I do in certain situations. I will say, though, this is all with the caveat that often, because of the side effects, including hand-foot syndrome being one of the most symptomatic that patients feel, a lot of the times my preference tends to be for infusional 5-FU. I know there is some logistical, let's say, downside to it in that you're hooked up to a pump through a Metaport for 2 days, but even if you take that with it, the side effect profile of infusional 5-FU, it tends to be much better tolerated, having much fewer side effects than capecitabine. So that is more often I go with FOLFOX using infusional 5-FU and then dropping the oxaliary rather than Capox. And even with 2 weeks instead of 3 week scheduled dosing, and even with the 2-day infusion, because it causes fewer side effects, in general, I have found, and I think is generally the case, particularly here in the United States, as some of the studies show compared to Europe with capecitabine, just based on the dietary differences. So one consideration would be, if you wanted to, perhaps ask your oncologist if switching to 5-FU maybe, which can cause hand-foot syndrome, but certainly not nearly as frequently as capecitabine. That's often my approach.
Yeah, I'm very, very similar. I basically only write capecitabine if I have to as part of a clinical trial. Um, but the pump is a pain in the ass. Everybody knows that. But I completely agree. On the balance, it probably is less side effects. You also don't have to remember to take 3 pills, twice a day, depending on the dose, which is not so easy sometimes. If a glass of water can fill you up after a gastrectomy. And if you need to be on capecitabine, it's not so easy. Ryan, I'm going to come to you. Speaking of 5FU and capecitabine, there's a question from Carmita in the chat. This is about adding capecitabine in a later line setting. So third line, irinotecan and ramucirumab. Question is, would you ever consider converting this into a 3-drug regimen? And the specific question was adding 5FU or capecitabine.
Mm-hmm. Yeah, so that's a good question. I think it's one question that it sort of depends on is how well a patient's doing in the third line setting. They've already gotten 2 different lines of chemotherapy, so sometimes 2 chemotherapies may be a little bit harder to tolerate at that time. So that may be one reason why an oncologist might recommend just doing the irinotecan instead of adding the 5FU. And in general, with the irinotecan combination, we would add the 5FU or FOLFIRI regimen as far as the chemo portion. The ramucirumab is an antibody drug that targets some of the proteins involved in blood vessel formation, and is something that could be added to the chemotherapy, either the FOLFIRI irinotecan or in the second line setting with paclitaxel. So I think if patients doing well functionally, oftentimes I will consider the FOLFIRI ramucirumab if they haven't gotten the ramucirumab earlier on as a third line treatment. If they're having more chemo side effects, are a little bit more frail, then we might just do one chemotherapy with the irinotecan.
Yeah, I agree. I think that's pretty much how I would think through it as well. I'm going to give this is maybe a little bit more of a surgical question, but I think Sam, you can probably handle it. So, someone who has a stage 2 adenocarcinoma had written in ahead of the meeting, no spread to any lymph nodes, is planned for a total gastrectomy. And the question is, while you're in there, do you take out other stuff? Specifically, do you recommend taking the gallbladder out?
I do not believe they go and take out the gallbladder after, it's a big enough surgery. I think they're focused on the area of the tumor, making sure they take out, with negative margins. And it is important that they do an appropriate lymphadenectomy and get a large number of lymph nodes, because that really is a signal for the likelihood of the cancer coming back. And we want to make sure that we have that information and help use it to guide our treatment. But outside of the organs where the cancer is, either the esophagus or the stomach, they're not they should not be removing any other organs, unless of course it's in some way adhered to it, I suppose. But I would say no, they should not be removing the gallbladder just because they're in there anyway. It's not that surgically simple. I know even as a medical oncologist, I sometimes try and oversimplify surgery, no surgery, make things a little bit binary, but having journeyed into the OR to see how complicated some of these things are, it's you don't want them removing more than they need to.
Yeah, I agree. I think, first principles, get in, get out, do the right cancer surgery. Yes, even if there are gallstones, I think even if there may be a normal indication for a gallbladder surgery, you wouldn't necessarily extend the operation for the cancer. I completely agree. There is a very common question that I'm going to let Ryan, you start with, and then I'll come to Sam, and it's about HIPEC. So can you broadly discuss sort of, are there people when you see them that you think maybe a candidate for, let's broaden it to peritoneal-directed strategies sort of as a whole?
Mhm. Yeah, so there are a few different ways to try to give peritoneal therapies. One that was mentioned was HIPEC, or heated intraperitoneal chemotherapy. So the chemotherapy is, heated to higher temperature and then instilled. Um, Chemotherapy can be introduced into the peritoneum, without being heated. So that would be sort of what we call intraperitoneal chemotherapy, not the heated part. There are some other, types of intraperitoneal therapies that you may hear of or under investigation, such as pressurized intraperitoneal chemotherapy, or PPAC as well. I'd say that the jury's still out, in my view, of which patients are would truly are the best patients for these therapies. We don't have a lot of great randomized data to tell us that this patient should definitely get intraperitoneal therapy. And there are some potential risks or side effects with intraperitoneal treatment as well. You can imagine, if you're instilling a lot of chemotherapy into the abdominal cavity, there can be bowel discomfort, abdominal discomfort, and other sorts of side effects that can occur with intraperitoneal therapies. So I think, if our institution doesn't have, it's not a routine type of procedure that we do for gastric cancer. For other types of tumors, such as appendiceal cancers, HIPEC may be more common. So I'd say, if there's a consideration for some of these intraperitoneal therapies, it might be good to see if there's any sorts of clinical trials that may be available. For example, one trial occurring here in the US is something called the Stopgap trial, where they're looking at intraperitoneal chemotherapies in patients who have had good disease control with their systemic chemotherapy regimens. I'd say for anyone considering some of these therapies, it's important to consider sort of the volume of cancer in the peritoneum. So a patient who has a lot of visible tumors on the CAT scan, very bulky disease, probably isn't the best candidate for some of these therapies. Rather, if there's very limited amount of intraperitoneal cancer, then that might be a situation where might be something that can be considered, again, likely in a very multidisciplinary discussion and perhaps on a clinical trial basis.
Yeah, agree on the clinical trial point in particular. Intraperitoneal chemo always made a little conceptual more sense to me. It always felt weird that a one-time treatment would be kind of the answer with a HIPEC, but I guess we'll see where that trial from ASCO GI goes, whatever the Dragon study. Sam, do you guys think similarly, like highly selective, low burden of disease trials?
Yeah, very much so. And I mean, the reasons are a lot of what you said, to try and perhaps capitalize on a longer period of benefit and maybe a small amount of stubborn areas, but it's not something that's going to, in from everything we've seen, heroically save a situation that has otherwise been quite resistant. And especially, in situations where there's disease outside of the peritoneum, and you run the risk of doing harm by kind of taking your eye off the ball, so to speak, and just trying to focus on one area. So we're very much in line. I'm
Yeah.
very much in line with what you both said.
I think so. I think, most of the peritoneal data is also before we had some of these things like Claudin, immune therapies and HER2 therapies, where we actually have better chances of response with systemic therapies. I want to get to the second poll, which is really about where you all who are here stand in treatment, if you're on treatment. So if we could bring up the poll question. All right, so if you can't see it, it asks about whether you're still waiting on staging, whether you're on chemo, immunotherapy. Obviously, there can be some overlap here, and how many people are on a clinical trial. I think this is always an interesting one. So as you can start to see, you've got 20 people answered this question so far, and almost 80% are on some form of chemotherapy, 50% are on immunotherapy. Nobody is on a clinical trial right now, which is, I think, somewhat of a sad reflection of how bad we need more trials to study some of these questions. I'll give it another few seconds, but of the 20 people that answered, 80% on chemo, 50% on immunotherapy, 10% on other, and one person is scheduled for surgery. Nobody on a clinical trial. So I think this is something that these town halls can kind of remind and all of us, especially us on the provider side, that we really do need to get pushing on clinical trials. And thankfully we've had some successes, but there's also a lot of parts of the country that are not serviced by access to clinical trials, which is another big problem. All right, back to the questions. I'm going to come back to you. Actually, I'll start with you, Sam, since I gave you first dibs on the last one. This is Simon's question in the chat. Again, a little bit of a nuanced question that I only learned what histotripsy was like 2 weeks ago, to be honest, from our pancreatic and biliary team. But have you had patients do histotripsy for liver metastases? This is someone, obviously a very particular situation with prior liver-directed therapy on Y90 and some biliary stents. So maybe I'll broaden it. You can also talk about histotripsy, but do you think about liver-directed therapies in people with liver-predominant disease?
Yeah, it's I actually have not had anyone on histotripsy before, and I'm just looking through the questions, seeing what else they've gotten. Y90, and seems like chemoembolization is maybe not an option. But I mean, it is a challenging area, and similar to how we were talking about how the peritoneum is, in some ways we think about it as its own. We can treat it separately. Sometimes we can treat the liver separately, and the way I think about each of these is, certainly in a multidisciplinary fashion, talking with the surgeons if that's appropriate, but interventional radiologists, radiation oncologists, and the like. And really, is there a single lesion that's perhaps growing out of proportion to the others, to which we're more concerned? And what's the baseline liver function? Because if there's a great deal of liver disease that's impeding liver function, then the toxicity with any of these treatments, your threshold tends to be a lot lower. You have your margin for error, I should say, is a lot lower, because any sort of normal liver nearby that's harmed, and you're risking sending them into more significant liver dysfunction. So I don't have any personal experience with histotripsy, though.
Yeah, me neither. I don't. I think it, as you said, very selectively think about ablative things like SBRT or Y90 in focal situations. I'm going to get to Lawrence's question that was submitted ahead of time, and I'll come to you, Ryan, for this one. I see Lawrence is on. You can ask yourself, or I can read it because you wrote a clear question. I'll start and then you can jump in if you want. But Lawrence was initially diagnosed with stage 2B gastric cancer in 2021 and underwent a partial gastrectomy and what sounds like perioperative chemo. And then in early 2024, had a nodal recurrence only in some D2, D3 nodes, and then was put on treatment at that time since last April, so just about a year ago. Sounds like great to hear, an excellent response. The nodes resolved on the last CT scan. People are entertaining the idea of repeat exploration and surgery since this patient is young. And apparently the EUS and endoscopy on the remnant stomach after the partial gastrectomy is completely negative, although there still shows some diffuse uptake on PET. So 2 questions. One, do you ever think about consolidation with local therapies like surgery in recurrent settings after a long period of excellent response? And maybe I think this is a common thing for all of us, this sort of persistent FDG uptake in the stomach, even in people that, or even could be the esophagus in people that have no stomach. So maybe take the first question on consolidation, local therapies.
Mhm. Yeah, a great question. I think, a common question that we receive in these town halls are, when do you consider surgery, particularly in a recurrent or metastatic stage 4 setting when there's been a good response to treatment? So I think, one thing is that, we don't want to jump in to a surgery if we don't have, good disease control. So oftentimes it is sort of the test of time and making sure that that the cancer has responded, well to the treatment, over many months or if not years. And there are, patients who can, do very well and have, really long-term benefit from systemic treatments, particularly in the era of immunotherapy or targeted therapies. So in this situation, when there's really no evidence of, strong evidence of any cancer, I generally, wouldn't jump to surgery necessarily in this situation. If we do have, evidence, of cancer, say from a biopsy that's still positive and everywhere else has been under control for a long time, that might be a situation where, I might think about surgery. And in terms of the PET scan, I think it, PET scan, oftentimes, we get asked about PET scans or think about them. It's important to note that PET scans aren't necessarily specific for cancers. A PET scan is a scan where radiolabeled sugar is injected and lights up into areas that take up that sugar, metabolically active areas. So sometimes that could also be, inflammation if that lights up and not necessarily cancer. So oftentimes, we may have trouble sort of determining, what that exactly represents, and sometimes that there can still be, thickening of the stomach even after treatment, and then that could also just, represent, sort of scarring, not necessarily active cancer as well.
Yeah, I agree. I think, I've almost taken to when people are like 6 months into a really good response, if they presented with stage 4 and have the intact primary tumor, I've almost taken to universally scoping these people if there's no other disease, just to assess the status of the primary. Because if they have nothing, if there's no primary left either, then it's really hard to think that you're going to get much out of an operation or chemoradiation or something like that. But I agree, it's probably going to be a situation we're going to all be facing a lot more common now that our systemic therapies are working better. Sam, I'm going to come to you, which might be one of our second to last questions. This is about complementary and alternative medicine and sort of how you guide people on that. So question came from Margie in Beverly Hills, Michigan. I did not know there was a Beverly Hills, Michigan. So reading about some complementary and alternative substances for both treatment of symptoms and treatment of cancer. So in the absence of sort of the same level of data that we hold clinical trials to, how do you sort of counsel patients about the use of complementary therapies?
Yeah. And there must have been something floating around, or I guess, presented recently, either in the news or social media, because I hadn't heard about some of the drugs that were mentioned on the question until a few months ago. And then I get questions about them all the time. But so I do want to say that, look, we are always looking for if there is anything that can help improve the treatments that we have, right? Because we know they're inadequate, because not 100, we don't prevent recurrence in 100% of people. So we need to continue to do better. But a lot of these other medications, ivermectin, berberine, there may be, and I'm always inquiring as to what article is, prompting this question. And there is no randomized phase 3 study, or there's even large study showing that the addition of these medications improves how patients do. The articles that frequently we are sent that prompt these, and I'm not to presume what was prompting this, but often what is the case is they are either opinion pieces or there are some preclinical studies, meaning something done in the lab that may show there is some anti-cancer activity in, in a laboratory. And unfortunately, a large majority of testing that's done in the lab doesn't actually pan out and help people. And so my biggest concern with a lot of these medications is many of them may be benign and not harmful, but many of them may in fact be harmful, and not just harmful in the sense that they cause toxicities and side effects to the person and make them feel unwell in a way that they won't be able to tolerate the treatment that we know and that has been proven to work. But they also may, some of these treatments interfere with how chemotherapy works and may limit the efficacy of the treatments that we know that work. And so that's generally the conversation that I have, and the answer I would give specific to the medications that were listed here that I mentioned. And if there are questions about that, I generally also try and refer them to an integrative medicine doctor, because there are some integrative medicines and supportive medicines that can be helpful, and just want to make sure that they're not anything that's going to interfere with the chemo that we know works to the extent that it does.
Yeah, I think that's, we're all, again, fortunate enough to be at places where we have integrative medicine centers that we can refer patients to, which is the same thing that I do. Two last questions, one quick, and I saw that one that just appeared in the chat. So Ryan, this one is for you. Quickly, let's say someone is on Folfox and nivolumab and transitions to single agent and nivolumab, and they have a great response at 1.5 years out or 2 years out. Like, how long do you treat people?
That's another really good question, and I think we don't have a definite answer of how long patients need to stay on immunotherapy. Oftentimes some of the trials have left that sort of open-ended, and patients have continued to receive immunotherapy as long as they're benefiting. Some have had a cutoff, for example, 2 years, but we don't have definitive duration. So oftentimes we'll continue on with the treatment, and great if that response has lasted out 1.5, 2 years. If patients are doing well, and maybe they've had a great complete response, I might discuss maybe having a break at that point in terms of monitoring, and that might be another area in the future where we can use some of these newer techniques like circulating tumor DNA to help guide us. Some patients are a little bit more hesitant to get off the immunotherapy, and I'll continue on. We've had patients on it for several years even.
Yeah.
So it's not a straightforward answer.
Totally agree. I want to give the very last question to, it says Google Pixel 8, but Abraham, if you don't mind, please feel free to speak up. Might be on mute.
Do you hear me now?
Yes, we hear you now.
Oh, okay. This is Abraham from Ontario, Waterloo. Thank you so much for this amazing meeting. I had TG 2 months ago. Before that, I'm in total gastrectomy. And before that, I had a 4 float chemotherapy. Now I'm having another 4. And in the beginning, I was told that maybe I was like in stage 2 or 3. But after the operation, after the surgery, I was told that I'm in stage 4. And now, when I talked to my oncologist, I was told that maybe I'm cancer-free, or maybe I have like 60% or something. It might come back. My cancer comes back. So I'm really confused, like about my health, what I need to do, and how this spectrum can be so wide, from cancer-free to like 60% coming back.
Yes. Can I ask you one clarification before I
Sure.
let Sam. So why did they tell you you were stage 4? Was something found in the surgery or?
Yes, they took 23 lymph nodes, and three of them had positive from the prenota, what do you call it? Pretona, around the pretona. And so 23 out of 24, it had cancer
But
that they found.
as
But
far
they cleaned everything. They told me they cleaned it.
everything they could see was removed, as far as you know.
Yes.
That's awesome. Well, that's always a good place to be. So I'm glad that happened. But
Thank you.
do you know, did the pathology report say this? Did it say like T3N2, or did it have numbers? I don't know exactly if patients get their reports in Canada or not.
Yeah. We can see that, but I don't know if it was. I think T3, something like that. Yeah. And 1N or something. I can't remember, but we have the report. We can see our report.
Yeah. Well, Sam, maybe you can talk just a little bit generally about, would you still give someone post-op FLOT? Because it sounds like that's what you're planned for. If, let's say, there's a no response or limited response to the neoadjuvant.
Yeah, I think what we're, what the question that you're getting at and what you're thinking about is, well, there was still some cancer there, and what the oncologist is worrying about is maybe not, when we see that the cancer is still in the lymph nodes, it sends us a signal that even if it's spread in the immediate area, there may be something else that we can't necessarily see that's circulating, right? And that's what the risk of coming back is. And so that's why, even though after everything has been removed, the goal of the chemotherapy that you're getting now, which, as Dr. Klempner mentioned before, a quarter of patients aren't even feeling strong enough or well enough to be able to start chemotherapy after. And it sounds like you're most of the way through the 4 cycles. We know that more than half of people don't even get that far. So you're really in already. It's a big deal to have gone through the treatment that you went through initially, to have gone through such a large surgery and have recovered well enough to get the treatment after, because the majority of people don't feel necessarily well enough to go through all of those steps. And the goal of the chemotherapy now is to treat the enemy that we don't see, right? We know that because they see the cancer in the lymph nodes, that is in a lot of ways a surrogate to us of that cancer may still be persistently circulating elsewhere that was not eradicated with the first chemo that you got. And that's the goal of what the chemo is doing now, is to try and lower the risk as much as we are safely able to do to prevent it from coming back. I don't know if that entirely answered your question. I do see there's a little bit of confusion, but hopefully I didn't make things more confusing.
Yeah. Very quick. I was told in the beginning, maybe I need, my surgeon told me that maybe I need radiotherapy, but then the radiotherapy doctor told me that, it doesn't, I don't need it. I don't know the reason, but is it bad or good?
The radiation to treat this disease, it has previously been used, and there may even be folks on this call who have gotten radiation to treat this disease. But in the situation in which you're in, which it sounds like initially thinking it was locally advanced in the area and has not spread, the strategy that your doctors use to treat you is what we do at our centers, and that was very recently shown to work better and lower the risk of it coming back compared to doing radiation, because radiation only works where you point the radiation, and the chemo works everywhere, and the surgery is just as good at the radiation as taking it out. So it sounds like your doctors had the right strategy to treat you.
Yeah.
Thank you so much. Thank you so much. What you are doing is really great. Thank you so much. Thank you.
I agree. No, thank you. Thank you for sharing. It sounds like you're being well taken care of, which is great. Thanks to everybody for staying on a minute or two late. Really quick reminders, there is a Debbie's Dream cooking up demo tomorrow, April 8th. And then there is support groups in the future. And then about a month from now, we'll have the next town hall for more questions. So this is great. Thanks for everyone for committing the time, and to Dr. Moy and Dr. Cytryn, and I will see you guys all pretty soon.
Thank you.